Good afternoon, everyone. It is my pleasure to introduce today's speaker, Dr. Ewan Goligher. Dr. Goligher, like Dr. Malhotra in our division, like Dr. Jassel, is from Canada. He received his Bachelor of Science in Biochemistry and his MD from the University of British Columbia before moving to the University of Toronto, where he completed his residency training in internal medicine and fellowship training in critical care medicine. And lest anyone think he was taking the easy way out, he then undertook additional training as part of the clinical investigator program of the Royal College of Physicians and Surgeons in Canada and the clinician scientist training program at University of Toronto, and received his PhD from University of Toronto in 2016. He currently serves as an assistant professor of critical care medicine, as well as of physiology at the University of Toronto, and has really established himself as a rising star in our field. He is really changing the way that the field thinks about acute respiratory failure, thinks about mechanical ventilation, and has had important input into the way in which we conduct clinical trials on these diseases as well, implementing novel adaptive methodologies as well. So we're very excited about Dr. Goligher's talk today, to breathe or not to breathe, answering a fundamental question in the management of acute respiratory failure. And if you need more Dr. Goligher, tune in for pulmonary grand rounds tomorrow at 7:30 as well.
Oh, thank you, Dr. Mandel, for the introduction, and thank you, everyone, for the opportunity to present today. It's been a tremendous pleasure to visit UCSD and to meet a lot of people working at this great institution, a lot of exciting and fascinating work going on. And it's an honor to be invited to give medical grand rounds today. So as Dr. Mandel mentioned, I want to present on this, what I believe is a fundamental and fascinating question in the field of respiratory failure: to breathe or not to breathe. What is the answer? So just some disclosures. I will very briefly mention some work I'm doing with a number of companies on diaphragm stimulation, and I do receive some consulting fees from those companies. So I was asked at the outset to attempt to humanize the presentation, and I thought that was an interesting challenge, one that isn't normally posed, and I had to reflect on exactly how I wanted to address that. But I thought that it might be appropriate to share a little bit of what drew me into the field of mechanical ventilation and respiratory failure, and in particular, what got me very interested in respiratory muscle function and in mechanically ventilated patients. And I remember as a young junior resident, second-year resident, working in the ICU for the first time, a particular patient whom I'll refer to as Mr. Wilson. I've changed some details to protect identity, of course. But this was a gentleman who was about 58 years old. He had alcoholic liver disease and cirrhosis. And he had a protracted course of mechanical ventilation for community-acquired pneumonia initially, but had recurrent ventilator-associated pneumonia. And what I remember is he was the patient whom I took on as a personal challenge to try to wean off the ventilator, and really struggled to understand just exactly why this patient wouldn't come off the ventilator. And at the time, I think respiratory muscle weakness was less on the radar than it is now, and so it wasn't something that I thought about so much. But one of the kind of clinical questions that we wrestled with on a nearly weekly basis for the duration of the rotation was whether to drain pleural effusions or not to promote liberation from the ventilator. And I found that the answer to that question was very attending dependent. And anytime something's attending dependent, it means you don't really know the answer. So I undertook some research in that space, did a systematic review. And one of the kind of striking findings that I came across was work by Marcus Stan and Andre Detroy from Belgium done in the early 1980s, where they demonstrated that actually the biggest and most important physiological effect of draining a pleural effusion, a large effusion, is actually its impact on respiratory muscle function. And this figure here on the right highlights the shift in the pressure volume curve of the respiratory muscles. So the x-axis here is maximal inspiratory pressure, and the y-axis here is the lung volume at which the patient's operating. And you can see that after drainage, the curve is shifted to the right. So the patient's able to generate much greater inspiratory pressure at a given lung volume. And then finally, the other thing that really struck me about that patient was the fact that he spent his entire time alone in the ICU and ultimately died alone. And one of the, I think, genuinely tragic things that we see in caring for patients at the end of life is to watch people die alone. There's something profoundly sad about the idea of someone dying alone. And I think it's actually even perhaps one of the privileges of our work is to accompany people in their journey towards death so that they're not at least entirely alone as they face the end. But around that time, I was introduced to, I was thinking about pleural drainage. I was coming to recognize the importance of the diaphragm. And then somebody passed me this paper, which was by a giant in our field, Martin Tobin, and, along with Franco Laghi and Amal Joubran, who highlighted this emerging issue of ventilator-induced respiratory muscle weakness. And this paper really drew me in because it brought together, general issues in mechanical ventilation and the challenges of assessing respiratory muscle function and the possibility that the mechanical ventilator might be bad for the diaphragm, which I'll touch on more. But with this kind of as the kind of problem that I wanted to wrestle with in our field, I was totally hooked. And that's how somebody ended up persuading me to stick around and do a PhD, et cetera. So just by way of a little bit of background, to remind everyone of the mechanics of breathing, because I know it's not what all of us wrestle with on a daily basis. Breathing is a relatively simple affair. The respiratory muscles function as a pump. During inspiration, they contract to generate negative pleural pressure, as shown in the tracing here. And as that pleural pressure drops, alveolar pressure drops, and that drives inspiratory flow, and the tidal volume rises. And then as you reach the peak of the tidal volume, the alveolar pressure is equilibrating, and you exhale, and the alveolar pressure rises slightly, which drives expiratory flow. Now, this is why this is called negative. Normal ventilation is referred to sometimes as negative pressure ventilation, because the alveolar pressures fall below zero. But on positive pressure ventilation, the patient's intubated, you're driving pressure and flow from the ventilator, and the alveolar pressure is positive, and the swings are positive rather than negative. And it's this interaction between the action of the respiratory muscles and the effect of the ventilator, which will be something that we wrestle with over the next 45 minutes or so. Now, mechanical ventilation wasn't really on the public's radar by any means until the outbreak of the pandemic just a few years ago, as all of us remember with a bit of PTSD. And it was at the time quite amazing to see articles in major newspapers. I remember the Globe and Mail in Toronto had an article about mechanical ventilators and what they were about. And here's an article in the New York Times where they actually take apart a mechanical ventilator to show people how they're constructed and how they work, and talk about all the challenges of ventilating a patient with acute respiratory failure. It was just amazing to see the kind of public fixation and also how good they were at communicating about it. But one of the things that really struck me was that they actually brought up this fundamental question, the difference between assisted breathing, where the patient's breathing on the ventilator, and controlled breathing, where it's entirely machine driven. They recognized that that was one of the challenges of figuring out how best to ventilate these patients, was to what extent the patient should be breathing. So that's really what we want to talk about today. So in the next 35 minutes, I want to briefly survey how we first got positive pressure ventilation, talk about its rise in history. I want to survey some of the key complications of positive pressure ventilation, why it's certainly no panacea. At the same time, we need to think about what are the risks attached to allowing the patient to breathe on the ventilator, particularly when they have an injured lung. And then I want to wrap up by summarizing how can we navigate between the Scylla and Charybdis, these two competing risks of injuring the patient with both positive pressure ventilation and negative pressure or spontaneous breathing, how we might navigate between those for the future. So the earliest report of mechanical ventilation is attributed to Andreas Vesalius, who was a professor of anatomy at the University of Padua in the 15th century. So Vesalius is famed for writing a textbook of anatomy called De Corporis Fabrica. And at one point in this book, he actually describes some experiments that he did, probably with vivisection, to demonstrate mechanics of breathing and ventilation. And he wrote that life may be restored to the animal. An opening must be attempted in the trunk of the trachea. So he's doing a tracheostomy into which a tube of reed or cane should be put. You will then blow into this so that the lung may rise again and take air. Yeah, it sounds kind of pretty familiar for those of us who work in the ICU. Vesalius described this very early on. Very like sort of dead in the middle of the Renaissance, when science was increasingly moving from being an armchair role where you sort of philosophize based on Plato's theories to actually getting up and touching body.
This. Okay, let me go start the share again. That looks like it right there.
Okay?
Well, let's see. Oh, this one's start right there. Okay, let me hide this.
Good. Okay, thank you. Thank you very much. No problem at all. So Robert Hooke was giving this paper and actually doing a live demonstration of ventilation before the Royal Society. So he has a live dog. He's opened its chest. He's tracheostomized it, and then basically describes ventilating the animal, then allowing apnea. Because the chest is open, the animal can't insufflate its own lungs. And he basically describes, on ceasing this blast, then suffering the lungs to fall and lie still, the dog would immediately fall into dying convulsive fits, but be as soon revived again by renewing the fullness of his lungs with the constant blast of fresh air. So again, very clear experimental demonstration of the necessity of rhythmic ventilation to sustain life. I'm skipping over a great deal of historical and technical development, but really the moment when positive pressure ventilation became an important phenomenon in clinical medicine was in the polio epidemic in the early 1950s. So up until that time, patients who developed respiratory failure, they'd attempted to use negative pressure ventilation with iron lung and various iterations thereof. And it was Bjorn Ibsen who trained in blood gas analysis in Boston and returned to Copenhagen, who theorized that these patients who were known to have a severe acidosis were dying of respiratory acidosis rather than metabolic acidosis from shock, which is what was widely supposed. And in fact, John West, whom I had the pleasure of meeting yesterday, tells the story beautifully in the Journal of Applied Physiology in 2005 for your reference. With the initiation of routine positive pressure ventilation, mortality from severe respiratory failure from poliomyelitis fell from just about 90% down to 40% over the ensuing months, really a marked and dramatic change. And this really precipitated the widespread uptake and introduction of positive pressure ventilation in the modern ICU around the world. In Canada, the first intensive care unit was set up in 1958 in the hospital where I now work at Toronto General Hospital. And it really, the 50s was the year when positive pressure ventilation really became a thing. But fairly quickly, both in the course of clinical investigation and from clinical observation, it became clear that the ventilator was not a panacea, that it could in and of itself injure the patient. And initially this was referred to as respirator lung syndrome. And this is a report from Canadian Family Physician from 1967, where they describe clinicians being concerned with the care of patients requiring mechanical ventilation have been impressed by the occasional development of gradually progressive deterioration of pulmonary function, apparently unrelated to the disease process that necessitated the respiratory assistance. So some new clinical pulmonary problem is emerging for patients on the ventilator, and this was initially referred to as respirator lung syndrome. So this brings us to think about what are some of the important complications of positive pressure ventilation that have been recognized. When we take over the breathing from the patient, if we leave them not breathing, what are some of the critical complications of the ventilation? Of course, the hemodynamic effects of positive pressure ventilation are widely appreciated. And this figure here is intended to illustrate the fact that the ventilator basically functions as a form of obstructive shock. It reduces venous return by pressurizing the pleural space to reduce the gradient for blood flow from the central venous volume back into the chest and the right ventricle. And depending on the degree to which the lung is overinflated by positive pressure, it also can obstruct flow through the lungs from the right heart to the left heart. And so these, very simple mechanical effects have very real and important hemodynamic effects, particularly for patients in shock, who are volume deplete with capillary leak syndrome, and who probably as a consequence of positive pressure ventilation often require liters and liters of fluid resuscitation that might not otherwise be necessary. So a very important hemodynamic consequence. And of course, the moment of intubating a patient with septic shock or acute respiratory failure is always a dangerous moment in that patient's life, because that transition from negative pressure to positive pressure can have severe hemodynamic consequences. The probably the most famous and widely discussed complication is ventilator-induced lung injury. So this is the idea that the ventilator, by overstretching the lung, can cause injury to the lung that would not have occurred in the absence of positive pressure ventilation. And this was classically described as experimentally induced pulmonary edema by Webb and Tierney in the 1970s, where they used high airway pressures to generate, as shown here on the right, acute hemorrhagic necrosis of ex vivo lung in comparison to a control specimen here where they were ventilated with relatively low pressure. So this description led to a number of important concepts. First of all, barotrauma. Subsequently, for various reasons, the concept evolved to also think about volutrauma, the injurious effects of excessive volume being applied to the lung, which I don't have time to get into, but is really still a pressure problem. And so this progressively led to the rise of the concept of lung protective ventilation with lower tidal volumes, which many of you may know issued in the publication of the ARDS and ARMA trial in 2000, which is still one of the seminal trials that shapes and informs daily practice in the ICU, showing the mortality benefit of lowering tidal volume to limit lung stress and strain. Why is the injured lung so vulnerable to ventilator-induced lung injury? Well, there's multiple reasons, but one of the most important concepts that we've acquired over the last 20 or 30 years is the idea of the baby lung, in which if you look at a patient with acute respiratory distress syndrome who's on the ventilator and you have a CT, typically what you see are two very well separated compartments, a collapsed, degassed compartment, and then still relatively preserved lung parenchyma remaining. And these remaining or residual volumes of the lung are sometimes referred to, at least functionally, as a kind of baby lung. And if you apply usual physiological tidal volumes to a baby lung, you'll generate often excess stress and strain. But one of the questions is why do these patients tend to develop this degree of atelectasis and collapse? Well, of course, some of it is because they're lying in bed and not moving, but also it's an important consequence of the fact that they're not breathing. And this is work by Alison Fraze and Charlie Bryan from the Hospital for Sick Children in Toronto, published 50 years ago now. And this is still one of, I think, the nicest descriptions of the impact of paralysis and diaphragm inactivity on the distribution of ventilation. So in a patient they characterized the distribution of ventilation using fluoroscopy. And what they showed is that in a patient who's awake and spontaneously breathing, the diaphragm has this kind of typical configuration, and most of the motion of the diaphragm, represented here by this grayed region, actually occurs dorsally. And as a consequence of that, most of the lung inflation is distributed, at least initially, dorsally, whereas in a paralyzed patient, the dome of the dorsal portion of the diaphragm is shifted upwards, and it shows very little cephalocaudal motion, and most of the motion of the diaphragm is now distributed ventrally. And so you can see how that very quickly leads to a distribution of gas primarily in the ventral lung regions and the progressive development of atelectasis and consolidation. So this is what raises the question, is it bad to leave a patient not breathing? And the development of that atelectasis contributes to the reduction in the baby lung volume, which then predisposes them to ventilator-induced lung injury. The next important complication of positive pressure mechanical ventilation that's now, I think, widely appreciated is the issue of ventilator-induced diaphragm dysfunction. And this was described by Knisley and colleagues in the 1980s in autopsy specimen of neonates who'd been submitted to mechanical ventilation for varying durations of time. So, and unfortunately, the neonates died, and then at autopsy, they took sections of the diaphragm muscle. And what you can see is that whereas at a few days, the myofibrillar cross-sectional area of the diaphragm is relatively preserved, in a neonate submitted to 47 days of mechanical ventilation, you see this marked myofibrillar atrophy. This was kind of the first clinical description of diaphragm atrophy during mechanical ventilation. And it was subsequently replicated in a large body of experimental work in a range of experimental models. And it became clear that this was potentially an important problem because diaphragm dysfunction is actually epidemic amongst mechanically ventilated patients. The best available data from this group from France, published in 2017, demonstrate that patients, the diaphragm dysfunction is exceedingly common. First of all, about 60% of patients have diaphragm dysfunction, and among those who have diaphragm dysfunction, it really contributes to poor outcomes. So prolonged weaning is almost all patients with diaphragm dysfunction have prolonged weaning. This is the prevalence amongst patients with prolonged weaning. I'm misinterpreting the figure here. So nearly all patients with prolonged weaning exhibit diaphragm dysfunction, whereas only a minority exhibit ICU-acquired weakness or limb muscle weakness, which gets a lot more attention. So this suggests that diaphragm dysfunction, a major contributor to difficult weaning from mechanical ventilation. So how does ventilator-induced diaphragm dysfunction occur? Well, experiments such as this demonstrate that one important mechanism is not breathing, disuse of the muscle. So in this animal model, you're looking here at force frequency curves of the diaphragm, which is kind of the gold standard technique for assessing muscle function. And you can see that in animals that are kept spontaneously breathing over a 24-hour period on the ventilator, there's no decrement in the force frequency plateau, no development of weakness. Whereas during controlled ventilation with diaphragm inactivity, there's a progressive decrease in the force frequency plateau, signifying the development of weakness. And what does that weakness develop? Well, there's multiple mechanisms linking disuse to dysfunction, but again, one of the critical ones is atrophy. So we already saw the autopsy specimens from the neonate study, but perhaps the classic study demonstrating ventilator-associated diaphragm atrophy in humans was published by Sandy Levine and colleagues. And here they compared patients' cases that had been ventilated as brain-dead organ donors for between 18 to 69 hours to control patients who'd undergone thoracic surgery for just 3 to 4 hours. And they took specimens of the diaphragm as well as pectoralis major. And again, you can see in comparison to the controls, this marked atrophy of both slow and fast twitch diaphragm myofibers, whereas there was no difference in myofibrillar cross-sectional area of pectoralis major between the two groups. So this was this rapid onset atrophy specific to the diaphragm associated with mechanical ventilation. Now, subsequently, we developed an ultrasound technique to quantify the change in the muscle mass over time. And this is some of our early data here, which demonstrated in a cohort of just over 100 patients close to half of mechanically ventilated patients develop this rapid early atrophy of the diaphragm. Some of the patients losing as much as 30 to 40% of diaphragm muscle mass in just a few days, highlighting that this is probably a very common problem in our patients, and that may well be contributing to the high prevalence of diaphragm dysfunction in this population. Subsequently, we were able to link these changes in diaphragm thickness to clinical outcome. So this is from a paper a few years later in a cohort of just over 200 patients. The y-axis is the daily hazard, or you might call it relative probability of being liberated from the ventilator. And you can see that in comparison to patients who have diaphragm thickness that's relatively close to baseline over time, the decrease in thickness over time is linked to a marked decrease in the probability of being liberated from the ventilator. And interestingly, there was a signal that an early increase in thickness of the diaphragm was potentially associated with poor outcome as well, although the numbers are much smaller and therefore the confidence intervals much wider, raising the possibility that we're observing some additional type of muscle injury that I'll discuss briefly later. And then I think another fascinating idea that actually we just wrote about very recently has been described in a few different papers over the last 10 years, but I think now is gaining a lot of momentum as a very important new area of investigation in our field, is this concept of ventilator-associated brain injury. So as opposed to secondary brain injury from injurious mechanical ventilation that patients with traumatic brain injury might sustain as a consequence of hypocapnia or elevated intrathoracic pressure, ventilator-associated brain injury is a primary brain injury that seems in all likelihood to be mediated either by systemic circulating cytokines or some type of neural signaling that drives the development of hippocampal inflammation and neuronal apoptosis. So this is still a very early concept that's really only been described experimentally. There's some evidence to suggest that it's mediated by excess lung stress and strain, and that lung protective ventilation may prevent ventilator-associated brain injury, but it's very early days. But again, highlights the fact that getting put on a ventilator is potentially no light thing, and this might explain the very high rate of cognitive dysfunction and delirium that we observe in patients after mechanical ventilation. All right, so that's a very high-level, rapid survey of some of the main issues in positive pressure ventilation and the consequences of rendering a patient not breathing. The question is it actually safe and acceptable to allow a patient to breathe when they have acute respiratory failure, particularly in the early acute phase? And so we have to also think about what are the risks of having a patient breathing during mechanical ventilation. So a concept that I think is quite intuitive, but only relatively recently described or characterized, is this idea of patient self-inflicted lung injury. So we didn't have time to get into it too much, but essentially when ventilator-induced lung injury occurs, the reason it occurs is because the lung is being subjected to excess lung stress and strain. And the ventilator is a pump that can generate excess stress and strain, but so are your respiratory muscles. And if you have substantial atelectasis and loss of lung volume in a small baby lung, well, the respiratory muscles pumping and the single unifying determinant of lung stress is the transpulmonary pressure, signified here by P sub L, which is simply the mathematical gradient between the airway pressure inside the lung and the pleural pressure around the lung. Now, traditionally, when we talk about lung protective ventilation, we've really only paid attention to what the ventilator is doing. And the way we do that is by looking at the airway pressure swings and limiting the pressure applied by the ventilator and the tidal volumes resulting from that pressure. But once you start to monitor what the respiratory muscles are doing during mechanical ventilation, you often see that patients are applying pressures to the lung that we would never be comfortable applying with a ventilator. And these tracings here illustrate the point. So you've got a patient breathing in pressure support with a positive airway pressure swing of about 10 centimeters of water. But if you look at the esophageal pressure swing, it's about negative 30 centimeters of water. So the total lung distending pressure is 40 centimeters of water, and the vast majority of that is from the patient's effort. And so, you know, there's no intensivist, I can promise you, who would ever apply 40 centimeters of water, well, except in very rare circumstances, maybe acute airway obstruction. But, you know, we would use pressures like that only with great caution. And so the fact that the patients are doing this to themselves is of great concern. Just how significant. Oh,
For you, Dr. Sharon.
okay. So the main point of this figure is simply to illustrate the fact that elevated respiratory effort and lung distending pressure as a consequence is very common in mechanically ventilated patients. So in this set of about 4,500 patient hours of data, here we're showing the hourly distribution of respiratory effort, shown in red, the esophageal pressure swing, the airway pressure swing, which is the action of the ventilator, and the two combined together represented in the gray. And you can see that many patients have lung distending pressures above 25 or 30 centimeters of water, which is what we would accept as an upper limit based on the pressure required to take you to total lung capacity. And many of these patients have markedly elevated respiratory effort as well. So it's likely that this is very common and that may be contributing to lung injury and to prolonged ventilation. And the issue is not merely the magnitude of the lung stress, but also the distribution. So when you have lung injury and established atelectasis and consolidation, the distribution of inflation during lung expansion generated by the respiratory muscles is no longer distributed homogeneously throughout the lungs, so that the dorsal lung can experience much greater stress and higher transpulmonary pressures than the ventral lung. And this is a phenomenon that was described in 2013 by Takeshi Yoshida and colleagues, where they used a technique called electrical impedance tomography, which the group here in the ICU has a lot of expertise with, to demonstrate the differences in inflation. And it's really quite striking. So if you look at this pattern of inflation here, when the patient's not breathing, you can see that the inflation is reasonably homogeneously distributed throughout the lung. Whereas in the presence of spontaneous breathing, you see that initially the dorsal lung inflates and only subsequently the ventral lung. And what that signifies is that the degree of transpulmonary pressure and inflating pressure and stress and strain in the dorsal lung greater than that even see just simply looking at the pressure at the airway with the ventilator. One of the kind of clinical features of this concept of patient self-inflicted lung injury is the development of barotrauma, which we actually saw at very impressive rates in patients with severe COVID-19, particularly those who had been on high flow nasal cannula, not intubated, clearly not really getting significant positive pressure ventilation, but having high enough transpulmonary pressures to cause significant injury to their own lung. This was quite common. Another injurious consequence of the patient breathing is actually injuring their own respiratory muscles. And the fact that you can load and injure the respiratory muscles is no great secret. It's been demonstrated experimentally multiple times. In this example here, electron microscopy, you can see the nicely organized muscle fiber architecture. And following resistive loading, you've got sarcolemmal disarray and inflammatory infiltration that develops over a period of 8 to 12 hours after the resistive loading is applied. And so if patients on the mechanical ventilator are generating very high inspiratory pressures, they may actually be injuring their own muscles. And in particular, if that loading occurs under what is called eccentric conditions, where the muscle's contracting, but the ventilator is actually already cycled into expiration and the lungs are deflating. So the thoracic volume is decreasing and the muscle's lengthening and it's still contracting. That can cause a particularly severe and acute injury, and that's referred to as eccentric loading. And conditions under which eccentric loading is likely to occur are various types of dysynchrony. Here are a couple of waveforms of two forms of dysynchrony, including reverse triggering, where the patient has a kind of reflex diaphragm contraction in response to the ventilator. And what you can see is that if you look carefully at this yellow line here, you see that the onset of the diaphragm activation measured here on a diaphragm electrical activity falls well after the action of the ventilator. And the diaphragm continues to contract as the patient's gone into expiration. And then eventually the diaphragm actually triggers the ventilator again. But for a brief period of time, the muscle's contracting even while expiratory flow is occurring, and that's subjecting the muscle to eccentric loading. And similarly, this type of dysynchrony here, premature cycling, where the ventilator is cycled off, but the patient's still making an inspiratory effort. And the consequence of that is a very abnormal expiratory flow tracing. And we recently demonstrated that this post-inspiratory loading, as we called it, is associated with a progressive loss of diaphragm function during mechanical ventilation. And then finally, another important consequence of allowing a patient to breathe on the ventilator is not only the effect on their inspiratory muscles, but also the action of the expiratory muscles. And this is a fascinating area of respiratory physiology that's really just starting to get some attention as we demonstrate lung mechanics in the presence of expiratory muscle effort. So if you look at these tracings here, this is essentially the tidal volume and operating lung volume here, measured with electrical impedance tomography. You see these large swings in pleural pressure measured by the esophageal balloon. And when neuromuscular blockade is applied, the magnitude of the swings comes down, signifying the cessation of expiratory muscle effort. And at the same time, end expiratory lung volume rises. So the vigorous expiratory muscle effort here is actually driving lung deflation, which is then predisposing the patient to increase lung stress and strain from a small baby lung. And interestingly, there's another population of patients where expiratory muscle effort was absent. And in that case, applying neuromuscular blockade really did nothing to improve lung mechanics. So this is probably an important determinant of whether or not paralysis is beneficial or harmful. So with that in mind, appreciating both having the patient not breathing has complications, having the patient actively breathing on the ventilator has potential complications. How do we navigate between this Scylla and Charybdis. And I'm not sure how your Greek mythology is. I confess mine's relatively limited, but this reference comes from the statement by Tobin and others in that paper from 2010 that I highlighted earlier, where they presciently, I think, talked about navigating the safe passage between the Scylla of excessive patient effort and the Charybdis of excessive respiratory muscle rest, the need to more carefully titrate ventilator settings. And they were arguing for monitoring respiratory effort based on the airway pressure waveform. So is there a kind of in-between state that we might refer to as safe spontaneous breathing? In our ultrasound data, we showed that there was an association between the level of diaphragm contractility and the duration of mechanical ventilation, such that very low levels of diaphragm activity over the first 3 days of ventilation and very high levels of diaphragm activity over the first 3 days of ventilation were associated with relatively more prolonged mechanical ventilation. And there was this very striking U-shaped relationship such that patients in the middle had the shortest duration of ventilation. Now, this is completely hypothesis generating, of course, but suggests that maybe targeting some optimal level of respiratory effort might allow us to improve the outcome. And so the big challenge, I think, going forward in optimizing ventilation, improving outcomes for respiratory failure patients is, can we optimize respiratory effort? And respiratory effort is affected by myriad factors in a patient in respiratory failure. Of course, the condition of the patient themselves, but also all the interventions that we apply to the patient, particularly sedation and ventilation, have significant effect on respiratory effort. And failing to optimize this may result in a range of consequences, including lung injury, diaphragm dysfunction, hemodynamic impairment, even brain injury, that drive the morbidity and mortality. And perhaps by optimizing effort, we can improve outcome for the patient. So achieve effort in related patients. Well, this is the result of a phase 1 trial that we completed in our center using this, what we termed lung and diaphragm protective approach, where we took patients with moderate and severe hypoxemic respiratory failure, adjusted the sedation to initiate spontaneous breathing at the earliest opportunity while they were still really quite sick, and then progressively adjusted ventilation and sedation to see if we could achieve the optimal effort level. And in this cohort, our success rate was really only about 43%, just because primarily the mechanical and gas exchange derangements were so significant. And what you see is that patients transition from an universal absence of respiratory effort to very high respiratory effort and lung distending pressures, and very few patients were able to be in kind of the sweet spot in the middle. And highlighting that respiratory drive and respiratory effort are very brittle phenomena. And this is something we were just discussing at ECMO rounds in the ICU yesterday. So what are some potential interventions that we could be studying to improve outcomes and to optimize respiratory effort? So one very promising technique, which is growing in use, is extracorporeal life support. This is the application of an artificial membrane lung and extracorporeal CO2 removal, which gives us very direct control over the ventilatory load that being delivered to the lungs. And you can really effectively control respiratory drive and effort or at least control it to some extent using this technique. And so for example, in our data, we showed that increasing sweep gas flow on average could significantly reduce the level of respiratory effort. Another very exciting technique is this relatively new concept of diaphragm neurostimulation. So here you have a patient who's on the ventilator, sedated, has no respiratory drive, and you deliver exogenous stimulation to the diaphragm via the phrenic nerve. And there's a range of techniques by which the phrenic nerves can be stimulated, but essentially it gives you direct fine-tuning control over respiratory effort. And this from this preliminary proof of concept that we published last year demonstrates the use of phrenic nerve stimulation to directly control the patient's respiratory effort in the absence of drive. So what you can see here is you have airway pressure, which is kind of normally the waveform we see on the ventilator. And when the phrenic nerve stimulation is discontinued, you see a fairly typical pressure time profile during volume control. But in the presence of stimulation, what you know is that the contour is markedly changed because you're generating negative pressure along with the positive pressure. And that negative pressure is being generated by the diaphragm contractions, which are signified by the cyclic swings in transdiaphragmatic pressure at the bottom. And when the PNS is discontinued, the diaphragm is inactive, confirming that the patient's not breathing. And so essentially what we're doing here is true artificial breathing. And in this trial, the results of which are forthcoming, we were able to maintain diaphragm activity around the clock in the absence of respiratory drive. One of the exciting developments is the development of platform trials. There's a number of platform trials in critical illness being set up, and the platform trial that I'm involved with in particular is practical. And within practical, we have a range of trials being set up to study specifically, can we achieve early, safe, spontaneous breathing? Can we use CO2 removal to get patients breathing safely and get them off sedation sooner? And the results of which are all forthcoming. So to summarize, I think we're on the precipice of an exciting new era in mechanical ventilation where we neither rely purely on negative pressure ventilation nor purely on positive pressure ventilation, but we see the ventilator and accompanying techniques as a means to achieve and restore safe, spontaneous breathing. There's a rich field of emerging techniques to achieve this, a growing appreciation for the impact of sedation and control of breathing under mechanical ventilation, but as yet a very limited evidence base to guide optimal management. And so this, I think, is going to be the exciting next 2 decades of our field to sort out whom and how and when to apply these various techniques to improve outcome and prevent injury. And with that, I thank you very much.
Thank you for that inspiring presentation, and apologies for the technical difficulties. Dr. Goligher's presentation is open for questions.
Just trying to think about how to separate kind of correlation from causation, because some of those things, the diaphragm thickness, sicker patients are sicker. The twitching thing you were talking about at the end might be one way to do that, where you can actually affect a change and try to thicken the diaphragm with twitching as an outcome and see if that extends to reduced duration mechanical ventilation and whatnot. Is that an approach you're taking to sort of define causal pathways rather than some of the stuff which is association, as you acknowledged?
Yeah, I think that's a very important point to make, is that a lot of this data, particularly in relation to its clinical importance, the impact on outcomes, is association, and causality hasn't been firmly established. And I think exactly this, that randomized trials are our opportunity to target these mechanisms and then to see how much difference it makes for patients. So, unfortunately, until you've done the randomized trial and had a positive result, you can't declare firm causality. But I think I would say that the breadth of experimental and preclinical evidence, which I didn't really have time to detail, together with the kind of clinical corroboration and fairly good replication across multiple groups, suggests that these are probably real issues that and therefore worth targeting.
Thank you for that talk. It was a great, you touched on brain-induced lung injury. And so, we always teach in the ICU for ARDS, hypoxia doesn't kill patients. It's multi-organ failure from ventilator-induced lung injury that causes multi-organ failure, and you die from that. But have you seen a PaO2 level that worsens, brain-induced lung injury? And the reason I ask that is, like, for our ECMO patients, we leave them on SATs of like 80, for long periods of time, as long as they don't have multi-organ failure, with PaO2s like in the 50. So I just want to hear your thoughts on that. Lung-induced brain injury. Thank you.
Yeah, thanks for clarifying. Yeah, so this issue of ventilator-associated brain injury. So I think they're probably 2 separate issues. The ventilator-associated brain injury experimentally occurs in the absence of hypoxia. So there's some mechanism unrelated to hypoxia that appears to drive neuronal inflammation and apoptosis. But I think you're still raising an important question as to what's a safe PaO2 in these patients. There's some circumstantial evidence to suggest that maybe there's more cognitive dysfunction when the oxygen saturation falls below, the 85 to 90%. But as you know, the most impressive relationship between PaO2 and outcome comes from all the data showing poor outcomes related to hyperoxia rather than to hypoxemia. So I think there's some uncertainty still as to what's the safe lower limit for PaO2. And the kinds of patients that you're describing where you're taking care of, sometimes 70 is just the best you can do. And so you live with it regardless. But I'm not sure that anyone's doing permissive hypoxemia when they could have a more normal sat. But I would say there's a fair amount of uncertainty about the safe lower limit for PaO2.
Thank you so much. Two quick questions. One is, has your research changed what your go-to initial vent mode is, whether it's pressure versus volume versus one of these hybrid modes? And the follow-up question is, how do you think PEEP affects your diaphragm dysfunction?
Great questions. So I would say the thing that my research has changed, the one thing that I feel quite comfortable recommending to people to implement in their practice is to routinely monitor respiratory effort. It's kind of funny that for the first 60 years of modern mechanical ventilation, we just paid attention to what the ventilator was doing and really none to the patient. We now have very simple techniques for monitoring respiratory drive and effort. And so I think, given these risks and their potential relevance, even the importance of prioritizing patient comfort on the ventilator, we should be routinely monitoring respiratory drive and effort. And so that's the thing in my practice that's changed. Do I think that there's one particular mode that's superior to another? Well, this is an interesting research question. My personal bias is that with any given mode, if you optimize the settings of that mode, at least with respect to this issue of the diaphragm, that you can achieve, safe, spontaneous breathing. It's just the critical issue is optimizing the use of that particular mode. I'm totally blanking on your last. Oh yes, the issue of PEEP. Yeah, so yeah, PEEP, very, very interesting. I think so. There's a hypothesis that applying high PEEP causes what some people refer to as longitudinal atrophy of the diaphragm, where it's maintained at a relatively short position for a longer period of time. Then when you take the PEEP away, it's kind of on the far end of the length tension relationship. And so you induce some kind of ventilator associated weakness. That's entirely unproven in the clinical setting. It's been demonstrated in 1 or 2 animal models. I think PEEP has a very important effect on respiratory effort. So if you're looking to optimize respiratory effort to achieve safe spontaneous breathing, then titrating PEEP is one of the first interventions to try. That's exactly how we do it in the clinical trial that we're running. So in some patients, turning up the PEEP will really settle their effort and improve their lung mechanics, and others, turning up the PEEP will, if anything, increase their efforts and increase the force of diaphragm contraction. So there's a lot of variability depending on the mechanics of the lung, the length tension relationship of the diaphragm, et cetera.
And then we have a question from Jess Mandel. Do you explain the failure of larger NMBA trials to show mortality benefit to patient selection alone? Other than defining high breathers and low breathers, are there other ways to better phenotype and predict NMBA responders?
Yeah, that's an excellent question. I was going to put a few slides in about this, and then for the sake of time decided not to put them in. But I think this is one of the important questions is, does this mean, this idea that it's bad for patients not to be breathing mean that neuromuscular blockade is injurious or inappropriate? I think there's some very interesting work that has come out or is going to come out soon showing that, among other things, the respiratory system elastance modifies the effect of neuromuscular blockade on mortality. So this is work done by Anzalaki and Carolyn Calfee that I've been involved with at UCSD that was presented at the ATS here last week, where patients with high respiratory system elastance and a small baby lung had a relatively high probability of mortality benefit from neuromuscular blockade, whereas those with good compliance and more normal lung mechanics actually tended to have harm from neuromuscular blockade. So I think that signifies the potential importance of paying attention to the lung mechanics. We also previously published some intriguing findings where we showed that the baseline diaphragm thickness moderates the effect of neuromuscular blockade on outcome. So patients with a very thin atrophic diaphragm, neuromuscular blockade in those patients was associated with worse outcome compared to patients who had a thick, more normal diaphragm muscle mass. So, and that was actually predicated by a very interesting case report where a patient with hemidiaphragm paralysis and unilateral diaphragm atrophy developed ILD, but only on the unaffected side. And so there seems to be, even in a more chronic disease state, some kind of interaction between the action of the respiratory muscles and the development of lung injury. So I think we're going to have more and more emerging information about in whom neuromuscular blockade might be most relevant.
If there are no further questions, thank you so much, Dr. Goligher. We're so grateful to you. And I'm sorry about I don't know what to tell you, the wired connection.